Hi there. Today I wanted to share with you a very, very important topic, which I believe is extremely quintessential to all of those who are going ahead and starting to do deformity correction or planning to take full length x-rays for realignment. So this is a PPT which I had made for the recent Assamicon midterm meet in the month of July, and this was presented in Patna. So here I'd like to share my screen with you and also whatever knowledge I can impart from the little exposure that I've had over the last decade. So the first thing of the talk is to focus on how to take a full length X-ray, and the components which determine a good X-ray are how we place the beam, how we compensate a short leg with a raise. We will be talking about the magnification and its calibration, any deformities, and also I'll be talking on stress X-rays. So why is alignment important? In this image, you can see what are the values for a normal alignment. This is important because any deviation from this will definitely cause issues in our day-to-day activities. So our aim is to actually restore this to normal in both the AP and also the lateral views. So the armamentarium comprises the X-ray machine, the cassette, and also the console. Adequately, we need to have about 10 feet of distance, which is 305 centimeters, between the beam and also the cassette. For this, a 15 by 15 wide room will be helpful, but maintaining this 10 feet gap is the most important part while taking a good standing X-ray, as you can see in this picture. Now, as per the right hand side, you can see that there's a blue arrow, and on the left hand side, there's a red color arrow. On the far right hand side, you can see that the child is standing on a raise and she's adequately able to position herself because there are sidebars. So having this in your armamentarium will actually add to the value and the quality of the X-ray that you get. So moving on, the cassettes. You can have 3 cassettes which can be stacked on top of each other. 17 by 14 inches cassettes are the best, but the problem is that each of these may have a radio opaque border. Now, for an adult, 1.3 meters. For a pediatric, 1 meter long cassette is sufficient. So whenever you're choosing your cassette, make sure that the edge is actually radiolucent. Here, if I would take your attention to the orange colored arrow and the rectangle, I am emphasizing particularly on that area which gets obliterated when you do not have radiolucency. So on the far right of the screen, if you would see that the stitching has been done by means of the console in between for the 3 cassettes that have been used for the hips to the ankles. Now the stitching is done adequately, and I'll be coming to the adequacy of stitching in a while. Here we can see that there are certain clips from the smallest to the largest arrow above downwards. These clips ensure that the alignment of the clips is done in such a way that there is no form of error. And the largest arrow at the bottom shows a particularly long 45 centimeter scale that's placed on the surface, which gives us an understanding as to where the patient is standing. So you can have 2 types of armamentariums. One is you can have a CR body, and the other one is a digital body, which is very common these days. The advantages of having a CR body is that it is easy to set up, the cost is pretty low, anybody and everybody can operate as it has a very small learning curve, and within one shoot, you will be able to get the entire limb X-rayed. Now, the advantage here is if a patient is pretty bulky, or if they're suffering from instability, definitely in between the shoots, you are going to have some amount of error. And for this particularly, I would like to go ahead and tell that if you are using a long cassette, it is definitely more beneficial than using 3 cassettes and 3 separate exposures. The amount of exposure from the bulb leads to decreased lifespan of the bulb, which is not a very good thing if you have your own setup and you would like to safeguard that particular bulb for a longer duration. So now coming to this particular slide where I'm showing to you the yellow colored arrow and the body of the DR machine, which goes up and down in order to ensure that you can cover from the hips to the ankle. The disadvantage here, despite its fancy software stitching modality, is that the amount of shifting a patient would probably do, even to a few degrees, will impact the quality of the X-ray and therefore the values that you would like to obtain while calculating the degree of deformity. So, moving on, this is the clip that I was talking about. These are placed in between the cassettes, and you can see very clearly as to how very well it has been overlapped to ensure that there is no amount of error. Now, coming to the beam center, this has been debated. A lot of people separately image at the hip, at the knee, and then at the ankle. But in order to maintain a protocol of things, I would like to go ahead and tell that when it is focused at the level of the knee, it will definitely cover from the hip to the ankle. And this is easily reproducible with a pediatric and also an adult patient, especially if you have the long cassette. So this will not entail you to have to stitch with difficulty. Everything would be covered in one shoot, and definitely any movement during this particular process will be not causing harm to your calculations. So one shoot, hip to ankle, and it is easily reproducible. Next, if a patient is known to have slight discrepancy at the level of the anterior superior iliac spines, we must increment on the side which is smaller or the side which is drooping down. As palpated here in this image, it goes to show that the raise should always be given in an increment of 1, 1.5, 2, 2.5, and 4 centimeters respectively. So when do you stop? As a radiographer, you would have to give instructions to the radiographer to stop giving rays. Is it when both the fingers are at the same level? No. The raise needs to be given adequately to the extent that the patient feels that both their legs are at the same level. And it should give a sense of stability to the patient in case they have one side which is shorter than the other side. Now, the tendency of anyone is to lean back onto the surface that is actually containing the cassette. So this is another important point that every radiographer should take into account before going ahead and x-raying the patient, so that the parallax error, the calculations, and any kind of discrepancy can definitely be minimized. So again, here, the importance of having sidebars to the patient who can feel a sense of stability while holding on. Next, the patella has to be ensured that it is central. So how do you do that? So you get the patient to bend and extend the knee. Once they bend and extend the knee, you know where the patella is, and then hold it with one of your hands. While at the same time, try to place the other hand, as shown in this image, onto the ankle. While holding the patella, ensure that you can rotate the foot and the ankle in such a way that the patella faces you. So this is very important for a case of genu varum. So what do you do for genu varum? Like here, you can see that the patella was centered. We have drawn our lines and we have aligned it using software. So What do you do afterwards? You go ahead and take a stress X-ray. Now, this is extremely important, especially if you're planning to do a knee preservation surgery. As a knee preservation surgeon myself, I would like to tell that both varus and valgus stress views give the amount of flexibility that the body still has to open up with our efforts of realignment with the necessary osteotomies. So as you can see here, the red color rectangle goes to show the X-ray which is taken without any form of stress view. But once we have tried to give a certain valgus thrust on both the sides, the green arrows indicate as to how very much it has opened up. Next, if you can focus on the image that is here, you can see how badly it is positioned. The patella is externally rotated. There's definite deformity on the right side. So how do you get to X-ray this patient? Because if you were to take an X-ray in this position, definitely the patella would be moving outwards, as you can see here, and that would give us wrong values. So the most important point that someone has to remember is to identify the flexion and extension axis. And once you bend the knee, perpendicular to that, you should be aiming your beam. This is a little bit cumbersome in the initial stages, but eventually it gets more comfortable in understanding and appreciating. So what are we looking for? We are looking for the joint line to be clear. And not just the joint line. Here the joint line is clear, but what is the problem? The problem is that I cannot see the intercondylar notch. Therefore, the limb has to be rotated in such a way, and the beam has to also be rotated in such a way that the intercondylar notch is clearly visible. That and only that can help us in understanding whether we are drawing lines properly or not for deformity correction. So like you can see here, it's not a very clear image, but I would like to go ahead and share with you the purple arrow position wherein it was taken without correction. But the orange arrow, as you can see here, is showing that the patella is central. The intercondylar notch, as pointed out by the red color arrow, is very clear, and also is the joint line. So gross deformities, what do you do for a gross deformity? Definitely, it is difficult to fit the entire set of legs in one frame. So the advantage by having a long cassette is that you can image each of them separately and stitch them up together. So such deformities also bring patients with instability and difficulty in standing for long duration. So what do? You make sure that you try to at least take the shoots very quickly if you have a DR imaging system wherein the shoots are taken in 3 separate sets. If you have a single long leg cassette, then even better, you can do 1 leg at a time. And also always make sure that your serrated edges of the clips in between the cassettes are very, very well overlapped, like I can show in this image. So what does it take to qualify for a good X-ray? First one is stitching. So whenever I see an X-ray, I ensure that the stitching is done well. Next, you can see here that there's a ball. This ball helps us in recalibration, which we will be discussing a little later. Next is the raise. So the amount of raise that you give, again, I have mentioned earlier, depends on the patient understanding whether the legs have a sense of equality or not. Look for the position of your lesser trochanter. It should not be peaking. It should be visible. It should be visible enough, but not overtly visible. The length of the neck, make sure that it is absolutely as normal as possible. There isn't any overestimation in terms of coxa valga. And like I mentioned earlier, the patella has to be centered. You should be able to see the joint space like you can see here. And also you should be able to ensure that you can see the ankle joint space. So revising, I can see the stitching is done well. I can see the ball well. I can ensure that the joint lines at the level of the knee and ankle are very clear. And of course, I can see the intercondylar notch if I were to zoom it. Here as well, I'm able to observe the patella is centered more on the right, a little bit less on the left side, but that's okay for now. And this patient actually should have been given a little bit, probably a 1 centimeter raise on the right hand side. However, it isn't given in this case, but it's a good point to remember. So here I have just shown the images for the particular purpose of ensuring that how giving a good raise can help us in understanding the level of the pelvis and how much compensation the patient feels is really adequate. So in cases where you are noticing the amount of lengthening that the patient needs is more or less similar to the amount of raise that we give, because the rest of it is already compensated by the spine. Here as well, I have shown you with the blue, red arrows as to how very much the equality of the limbs can be ascertained by giving a raise. Here, again, revising with all of you, the quality of X-ray showing the amount of lesser trochanter should be visible. It should not be peaking and it should not be overtly exposed. So these are three particular images which show the overtly exposed or severely externally rotated leg. This is the right amount of lesser trochanter that should be visible, and this is where it's incompletely visible. So take a decision based on what you see and modify accordingly. Now, coming to the lateral position, this is extremely important to understand the biplanar deformity, so to say. So in a lateral view, your condyles have to overlap, especially if you're taking a lateral X-ray for a limb which has multiple deformities, and especially if you're taking it in a standing position. So make sure that you internally rotate or keep it in neutral or externally rotate based on the situation, and the limb has to be positioned in such a way that your condyles overlap. Now, another point is the position of the ball. Here, as you can see, the sphere that I have kept is anterior to the plane of the deformity. So, coming to the next point, which is the ankle X-ray. The ankle X-ray should show me the joint line, and also in lateral X-ray, if I'm taking, I should be able to see the lateral process of the talus. So magnification. Always magnification is ascertained by using this sphere, which can be easily available on Amazon. Some people try to use a grid frame, but the problem is the further it is from the bone, then based on the patient's obesity at the level of the gluteus or the thighs, you're going to have a magnification error. Therefore, having a stainless steel ball is the best one, and it should be placed along the plane of the bone. By that, I mean, if you're taking a standing AP X-ray, the ball should be in the lateral plane, which is along the line of the bone. If you're taking a lateral X-ray, it should be anterior to it, along the line of the bone that you're planning to evaluate for any deformity. These images are taken from the center where I did my fellowship, the Center for Limb Lengthening and Reconstruction at Mumbai. So this is an example of a grid frame. And as you can see, this is the error that I was talking about, which gets added once the patient is further or not from the grid. So any deformities like kyphosis or any exaggerated pelvic deformities can add to that particular magnification. Now, what do you do for a patient who has gone to a diagnostic center and the ball isn't available? So you ask them to give you a scale on the side. And this has to be extremely credible, because normally the distance between two large lines is actually 1 centimeter, and we will be using this in order to calibrate. Now, for angles, you don't need this value so important, but for checking the axis deviation in centimeters, definitely you do need this value. Coming to the stainless steel ball, the minimum diameter that you should have is 15 to 20 millimeters, and you can get 25, 30 millimeter balls on Amazon. So what do? We sandwich this in a cloth, and edges of this have attachment to the Velcro. So what is the magnification multiplier? So always remember, the magnification multiplier is what is known, that is the value of the ball, by what you measure on your X-ray. So what is known to us is that the diameter of the ball is, let's say, 25 mm. But what we have measured is 31 mm. So my magnification multiplier would be 25 by 31, that is 0.8. So for every value which I get on the X-ray in length will have to be multiplied by this magnification factor. So let's see. Here there's an X-ray from the hip to the ankle. I have measured the length of 91.3 centimeters, but the exact value is going to be 91 into 0.8, which is 73. This is on Horos, which is a free software that you can get online and use it on your Mac. Let's see how right we are. This is another software which I got during my fellowship. It's called TraumaCAD. This is a paid software. So let's see whether this does justice to our calculation and whether we are right. So I'll take the length, I would recalibrate, and I would check that whether it's right or not. So now I'm getting a value of 73. So we're not that bad, right? So moving on, a lot of people keep a K-wire. That's about 10 centimeters between the leg and the frame. But what happens is, again, what happens with the grid? The magnification error definitely occurs. So therefore, my suggestion is that either you go for the ball for calibration or you use the scale. Here, like I mentioned, the distance between two large lines is 1 centimeter. Therefore, everything gets calibrated along those lines. So the issue is sometimes this can be not so credible. Sometimes it can have an issue with your software. But yes, definitely this needs to be used in those situations where you do not have a ball. So what are the take-home points? That a single long cassette is definitely better. 3 cassettes which are stacked on one on top of each other should be considered, provided the space in between is radiolucent. And always center the beam on the level of the knee so that you can cover from hip to the knee and ankle. Always take a stress radiograph in those varus knees and take valgus stress x-rays in your valgus knees. Magnification marker, like I mentioned, always use sidebars in those patients who cannot really stand still for long duration, especially if you're having a DR framework with you. So this is a very nice article which Mangal sir had written at the along with Dr. Tarandeep and Dr. Lalit Kumar. This is something which laid the foundation for me to understand how to take a full-length X-ray. And these are 2 books which I feel have really shaped my understanding in the art of taking a good X-ray. I would recommend everybody to go through this. These are beautiful books. And definitely there's George Paley's Principles of Deformity Correction. So I hope that this exercise has been helpful to all of you, and that I have been able to do justice to the same. I really sincerely hope that it will help you in taking your full-length X-rays. When the time comes, you'll be able to invest in the necessary armamentarium, like I mentioned, and that if you have any queries, I'll be more than happy to answer. Let me know if there are any. Thank you so much. Have a great day. Bye-bye.